Hello friends, whether you are a beginner or experienced surgeon, today's video is not only regarding the surgical skills for doing phaco emulsification, but my aim is to stress on how important it is to be slow and patient in each and every step. It does not matter how difficult the case is, you will get the good results if you are focused, slow and patient. Slow is not regarding speed. The good cataract surgery results means how precisely and accurately you have performed each and every single step. So now we have reached to the step where we are injecting the viscoelastic OVD into the anterior chamber before starting the capsular axis. It is good to coat the cornea with viscoelastic to enhance the view during the whole phaco emulsification. So just to stabilize the globe and make the main port with the help of 2.8 or 2.2 millimeter keratome. The incision should be very well squared and rectangular. To start with capsular axis, we raise a flap with 26 gauge needle and continuous curvilinear capsular axis is made with the help of capsular axis forceps. Be slow and patient while doing capsular axis, as I feel it is the most important step of whole phaco emulsification or cataract surgery. Try to do capsular axis with capsulotomy forceps only, as it is very controlled and safe to make capsular axis with forceps. So we do hydrodelineation and hydrodissection with BSS. It should be very gentle and slow. Here we get a very nice golden ring of the nucleus. It is very important and mandatory to rotate the nucleus as it will make easier later on to do the phaco emulsification. So to start with, I'm going to do the direct chop technique or vertical chop technique to perform the phaco emulsification. As this is a soft nucleus, soft cataract, so it is not that easy to chop the nucleus, because the dialer will cut through the nucleus every time you try to chop it, because as the core is very soft. So it is cheese wiring the nucleus every time. So I'm trying to get the chop, my first chop, and once I get my chop, and divide the nucleus. It will become easier to chop it further. So here I got my first chop. So divide the nucleus into two hemispheres, hemi-nucleus, and now we'll divide the nucleus into further pieces. Now grab each and every piece and bring it anteriorly and emulsify it one by one. You have to be patient in this coordinate removal step. I know once you have chopped the nucleus, there is an urge to get the nucleus as soon as possible to finish the surgery, but this is the only moment when you can go wrong. So don't be in hurry at any point of time. Just be patient. It's a matter of hardly 30 to 40 seconds if you do it slow, but you have to be very careful. Once you go wrong anywhere, it will be a big trouble. Your 10-minute case can extend up to 45 minutes or 1 hour. So be very slow. Just observe each and everything very carefully. See, the epinucleus is not coming up. It doesn't want to come or get into the phaco probe. So be patient. If it doesn't come out, do a gentle hydro and bring the epinuclear plate upwards. But in this case, it came out. So I did this epinuclear removal with the Phaco only, Phaco emulsification, and just take few little more pieces with the Phaco and just come out. Your dialer should never be inside the anterior chamber when you are coming out. So now we are going to perform the irrigation and aspiration of cortex. This is the cortex. Just keep a full eye all the time on the port, opening of the port of aspiration. The aspiration port opening should never be away from your eyes. You should know what you are taking in and what you are aspirating. This is the safest procedure. This is the safest trick. If your aspiration port opening is out of sight, there are high chances you will grab the posterior capsule or any other structure like iris, but most important is this posterior capsule, and if it occurs, it will spoil your whole case. Now you should do meticulous polishing of the posterior capsule. Don't be in a hurry. Any remaining with any remaining cortex or cortical fibers can lead to the extended inflammation post-operatively. So be very patient in each and every step. Now inject the viscoelastic to inflate the posterior capsule and anterior chamber. Here I am trying to perform to neutralize the astigmatism. We are loading the single piece hydrophobic IOL into the cartridge, and here we are injecting it into the first leading haptic is directly landed into the bag, and the trailing haptic is dialed gently into the bag. Now, after centralizing the IOL, the next step is to remove the viscoelastic. So be very patient and be very slow in removing the viscoelastic. The meticulous removal of viscoelastic is very important in decreasing the post-operative inflammation. There is a lot of viscoelastic is accumulated into the haptics of the IOL where the haptics are placed. So now I am using the hydro cannula to remove viscoelastic behind the IOL, and there are few cortical fragments also which needs to be removed. These minute things are important to determine the surgical results post-operatively. So we are removing the viscoelastic behind the IOL. These maneuvers you have to learn over the period of time, very slow and gradually. They are very important. So remove the viscoelastic from angles, anterior chamber, and swipe the angles of the eye also to remove viscoelastic. So now it's time to seal the anterior chamber by hydrating the side ports and main port. Also, I am hydrating the limbal relaxing incision that I have made to neutralize the astigmatism. Patient had -1 astigmatism, 1 diopter of astigmatism with the rule. Check for the leakage of side port. Thanks for watching.